Welcome back to The Deep Dive, the show where we take a stack of sources and, well, we really dig in to extract the most important, sometimes surprising, and often mind-blowing nuggets of knowledge, custom-tailored just for you.
That's the goal.
Today we're diving into something that, while incredibly tiny, has had just a truly massive global impact. It's fundamentally altered public health, scientific research, even, the most routine medical practices worldwide.
It really has. It's a powerful testament, isn't it? How something microscopic can force humanity to innovate so rapidly, to collaborate and really confront its vulnerabilities on a scale we hadn't seen before.
It feels like more than just a disease, it's a whole saga.
Oh, absolutely. A saga of scientific breakthroughs, definitely, but also human resilience, and maybe a stark reminder of that ongoing dance between us, human biology, and these microscopic life forms.
Absolutely. So our mission today is to embark on a really comprehensive deep dive into retroviruses. We're specifically focusing on the human immunodeficiency virus, HIV, and its progression to acquired immune deficiency syndrome, or AIDS.
We're going to break down the intricate science behind this kind of elusive virus, uncover its profound, often devastating effects on the human body,
trace the history of its global impact, and then explore how modern medicine and prevention strategies are tackling this ongoing, very complex challenge.
And for this deep dive, we're drawing heavily from two core sources. We've got our foundational document, DO5, Retrovirus, which gives us that essential scientific framework, the viral mechanics at a cellular level.
Oh, right, the nuts and bolts.
Exactly.
Yeah.
And complementing this, we have HIV and Dentistry, understanding infection and control. Now, this one offers a really unique, I think, incredibly insightful perspective. It details the clinical implications, especially how HIV shows up in the mouth.
Which is fascinating in itself.
And the huge impact it had on universal healthcare protocols. So, together, these should give us a pretty comprehensive, multifaceted understanding.
And why does this deep dive matter to you, our listener, even if you're maybe not in the medical field? Well, understanding HIV isn't just for clinicians or researchers. It's really crucial for general public health literacy.
Yeah, and for appreciating the truly astounding scientific advancements that have happened. I mean, what was once basically a death sentence is now, for many, a manageable chronic condition.
Yeah.
It's huge.
It really is. And it's also vital for understanding the ongoing global health challenge it still represents, and for recognizing the sheer ingenuity and collaboration that went into battling it.
Mm-hmm. The story of HIV, it's a remarkable journey. Scientific discovery, human resilience, global cooperation.
Mm-hmm.
It holds profound lessons, really, for how we might approach future health crises.
So let's begin this remarkable exploration. Let's truly unpack this, starting right at the very beginning with the fundamental nature of retroviruses. This is where HIV gets its intriguing retro name, which, as you'll discover, tells you pretty much everything about its unique, almost rebellious way of operating.
What makes retroviruses truly unique and, frankly, utterly fascinating from a biological standpoint is their astonishing ability to reverse the central dogma of molecular biology. Usually, genetic information flows DNA to RNA. Simple enough.
The standard way.
Right. But these viruses, they go backward. They possess this extraordinary enzyme that lets them transcribe their RNA genetic material into DNA.
Wow.
That enzyme is famously called reverse transcriptase. It's like finding a book and not just reading it, but being able to rewrite it in a completely different language backward right onto the paper it's printed on.
That's such a powerful image, rewriting the master blueprint in reverse. And HIV, the human immunodeficiency virus, is the prime example of this, isn't it? A real poster child for retroviruses.
Absolutely. And it's also a member of a specific subfamily called lentiviruses.
Lentiviruses. Okay, what's the key characteristic of being a lentivirus, and why is that significant for how HIV progresses?
Well, lentiviruses, like HIV, are distinguished by their ability to cause slowly progressive chronic infections. The word lenti itself, it comes from the Latin for slow.
Ah, makes sense.
Yeah, and it perfectly describes that often long drawn-out asymptomatic period before the full onset of symptoms. This slow but relentless progression is really a cornerstone of HIV's insidious strategy within the human body. It lets it establish a foothold and cause significant damage before any overt signs appear.
Okay, now let's zoom in even further. Let's get to the nitty-gritty of HIV itself, its morphology, its structure. When you picture HIV, what are we actually talking about at the microscopic level? Our sources describe it as an enveloped spherical virus. What does enveloped mean in practical terms for how it works?
Okay, imagine it as an incredibly tiny, almost perfectly round ball, meticulously wrapped in an outer layer or envelope. It's astonishingly small, only about 100 to 120 nanometers in diameter.
Which is minuscule.
Absolutely tiny. I mean, to put that in perspective, a human red blood cell is roughly 7,000 nanometers wide. So HIV is truly a microscopic speck. And inside that spherical shape, it has a distinct cylindrical core, giving it a very specific, highly organized internal structure. It's definitely not just a random blob. It's a precisely engineered viral particle.
So it's not just a simple bag of genetic material. It's like a sophisticated, multi-layered machine.
Yeah.
Let's break down these layers, maybe starting from the very innermost, the genome layer. What's the vital information stored right inside that core?
Right at the heart, the innermost layer is the virus's control center. That's where its viral genome resides. And what's quite unique about it is that it's diploid.
Diploid, meaning two copies.
Exactly. It contains two identical copies of single-stranded positive sense RNA. Most viruses just carry one copy of their genetic material. This double copy characteristic is a hallmark of retroviruses like HIV and is absolutely crucial for its replication process. It provides a sort of built-in redundancy, which aids its survival.
Okay, two identical copies of RNA. And then surrounding that precious genetic material, we find the middle cone-shaped nucleocapsid layer. What are the key proteins we find here, and what roles do they play in the virus's architecture?
This cone-shaped core is packed with several vital viral proteins. The most notable one is P24. That serves as the major core antigen.
P24, I've heard that's important for diagnosis.
Hugely significant, yes. From a diagnostic standpoint, its detection is actually one of the earliest markers we can use to identify an HIV infection, often even before the body has produced detectable antibodies.
Okay.
Then you also have P17, which acts as a matrix protein providing structural support, and P15. And these proteins, including that crucial P24, are all products of a viral gene called the GAG gene. They essentially form the robust structural scaffolding of the virus's inner core, giving it integrity.
It's fascinating how these tiny proteins have such monumental roles. And finally, on the very outside, we have the outer lipoprotein envelope. You mentioned it's enveloped. Where does this envelope actually come from, and what critical components are embedded within it that allow the virus to interact with our cells?
Right. This outer envelope is actually one of HIV's clever disguises. It's not originally viral material. It's derived directly from the host cell membrane itself when new viral particles bud off from an infected cell.
So it steals a bit of our own cell membrane.
Pretty much. It's essentially a stolen piece of human cell, which allows the virus to initially camouflage itself. But critically, embedded within this stolen membrane are virus-specific coat proteins. The two most vital ones are glycoproteins, GP120, which acts as a spike antigen.
Like the spikes on a coronavirus model.
Sort of, yes. And GP41, which is a transmembrane pedicle glycoprotein. Now, these aren't just structural. They are the absolute keys for infection. They act as antigens, so they provoke an immune response. But more importantly, they are the very proteins the virus uses to attach to and enter new host cells. They're like the virus's specialized handshakes that unlock our cells.
So GP120 and GP41 are the viral keys to our cells. Speaking of function, let's talk about the essential enzymes that are also packed within this virion. These truly define its retroviral identity and are the reason it behaves so uniquely, right? That retro part again.
Indeed. The first, and arguably the most famous, is RNA-dependent DNA polymerase, more universally known as reverse transcriptase.
The star player.
You can say that. This enzyme is encoded by the POL gene, and its role is paramount. It orchestrates that backward transcription we mentioned earlier, converting the viral RNA genome into DNA once the virus has successfully entered the host cell.
Okay.
Without this enzyme, HIV simply could not complete its life cycle. It's the ultimate Achilles heel that scientists first targeted.
Right, that was the big breakthrough for treatments.
It absolutely was.
Yeah.
It completely flipped the script on viral replication and opened the door for the first effective treatments. This single enzyme represents a biological anomaly that became, in a way, a beacon of hope.
And once that DNA copy is skillfully made, it needs to get integrated into our very own genetic material. That's where the enzyme integrase comes in, performing another astonishing feat, isn't it?
Precisely. Integrase, also encoded by the POL gene, is the crucial architect responsible for integrating that newly synthesized viral DNA directly into the host cell's DNA. This is a profoundly significant step because once integrated, the viral genetic material becomes a permanent part of our own human genome.
Permanent. Wow.
Yes, forming what's called a provirus. This permanent integration isn't just a biological curiosity. It's the reason HIV can evade our immune system for years, and why a true cure remains so incredibly elusive. It literally becomes a permanent hidden time bomb within our own genetic code, making eradication just incredibly challenging.
And then there's protease. What's its function in this complex viral assembly line, and why is it so critical for the virus's infectiousness?
Protease, again an enzyme coded by the pol gene, acts like a pair of molecular scissors. When the host cell starts churning out viral proteins, they're initially produced as these long, inactive chains called precursor polyproteins.
Like raw materials that aren't useful yet.
Exactly. Protease steps in to precisely cleave these large polyproteins into their smaller individual and functional components. Without protease performing this critical cutting and packaging role, the viral particles wouldn't mature correctly, and they wouldn't be able to infect new cells. It's absolutely essential for the virus to become fully infectious, which of course makes it another prime target for therapy.
So to summarize this intricate viral machinery then, we've got P24 as a major core antigen, the critical GP120 and GP41 on the surface. Those are coded by the INV gene, you said.
That's right, inframbo.
Right. And the essential enzymes reverse transcriptase, integrase, and protease, all primarily coded by the pol gene. It sounds like each of these proteins and enzymes plays a very specific, indispensable role in the virus's life cycle.
Absolutely.
And by understanding them so intimately, we can clearly see how each becomes a precise target for both diagnosis and, crucially, for effective treatment.
Exactly. Each of these components, in its precise function, represents a vulnerability that modern medicine has meticulously learned to exploit. And that's what has transformed the fight against HIV.
Okay, now let's delve into the incredible life cycle of HIV itself. You described it as a masterclass in biological infiltration, disguise, and relentless replication. And it all begins with how it infiltrates our bodies. What are its primary targets in the human body? Which cells is it specifically seeking out?
HIV has a remarkably specific and unfortunately devastating target. Cells that express CD4 antigens on their surface. Yes, the most critical of these are helper T cells, often just called CD4 plus T cells. These cells are the absolute command center, the conductors of our entire immune orchestra, coordinating and activating other crucial immune cells.
So it goes right for the top brass of the immune system.
Exactly. But HIV doesn't stop there. It also targets other cells of the macrophage lineage. Think monocytes, macrophages, dendritic cells, even microglial cells in the brain. So it further extends its reach beyond just the T cells.
So it's going straight for the very heart of our immune system's command and control. And how does it initiate that devastating attack? You hear it described as a meticulous lock and key mechanism.
That's a perfect analogy for the initial stage. The process begins with the GP120 envelope protein, that spike we discussed earlier, binding precisely to the CD4 receptor on the surface of the target cell. It's a highly specific fit, like the virus has a unique key designed just for that particular cellular door.
But it's not just one lock, is it? It needs a crucial co-pilot, another receptor, to gain full entry. What's the indispensable role of these co-receptors in allowing the virus to breach the cell membrane?
These co-receptors are absolutely crucial for viral entry. Without them, the virus generally cannot fully fuse and get inside. Typically, these are chemokine receptors like CXCR4 or CCR5.
CXCR4 or CCR5.
Right, and the specific co-receptor used can even differentiate viral strains. For instance, macrophage tropic strains, meaning those that primarily prefer to infect macrophages, often bind to CCR5. So even if GP120 successfully binds to CD4, the virus effectively faces a kind of two-factor authentication system.
Like for logging into a website.
Exactly. If that second password isn't provided by the correct co-receptor, entry is blocked.
And once it has both the CD4 receptor and the co-receptor, how does the virus actually merge with the host cell and get its precious genetic material inside? It sounds like a sophisticated maneuver.
That's where the other glycoprotein, GP41, comes into play. It acts like a molecular grappling hook. After GP120 binds to CD4 and the co-receptor, GP41 undergoes a conformational change. It changes shape, and that mediates the fusion of the viral envelope with the host cell membrane.
So they just merge.
Think of it like two soap bubbles seamlessly merging into one. This fusion creates a channel, allowing the viral core containing its RNA genome and those essential enzymes to be released directly into the cytoplasm of the host cell. The hostile takeover has officially begun.
Once inside, the virus performs its signature retro trick, reverse transcription. How does this unique backward transcription happen, and why is it such a defining and, well, vulnerable step for the virus?
Okay, so once the viral core is inside the cytoplasm, its RNA genome is uncoated, it sheds its protective layers. This is the pivotal moment. The retro aspect of the virus comes alive. The viral enzyme, reverse transcriptase, that RNA-dependent DNA polymerase we discussed, immediately gets to work.
Right.
Right away, diligently transcribing the single-stranded RNA into a double-stranded DNA copy. This is a unique and absolutely essential step that sets retroviruses apart from almost all other life forms. It's also, as you said, a key vulnerability. Many of our most effective antiviral drugs specifically target and shut down this critical process.
And after it's converted its RNA into DNA, it performs another astonishing maneuver. It becomes part of us, literally integrating its genetic material into our own. How does that integration into our host DNA work, and what are the long-term implications of this pro-virus state?
The newly formed double-stranded viral DNA copy is then carefully transported into the host cell's nucleus. Here, another vital viral enzyme, integrase, takes over. Integrase literally cuts our host cell's own DNA and precisely inserts the viral DNA copy into it.
It cuts our DNA.
Yes, and pastes its own DNA in. This integrated viral DNA is now called a provirus, and this integration is profoundly significant because it leads to a latent infection. The virus is now permanently embedded within our genetic material, becoming an essentially indistinguishable part of our chromosomes.
So it hides there.
Exactly. This permanent integration contributes directly to the notoriously long and highly variable incubation period of HIV, often lasting for many years without symptoms. And it explains why completely eradicating the virus from the body is so incredibly challenging. It's like a silent, hidden blueprint for more viruses, just waiting for its moment to activate.
So the provirus is essentially a hidden time bomb patiently waiting to take over the cell's machinery, and that leads us to the next insidious phase, taking over the host for replication and assembly. How does this integrated provirus hijack our cellular machinery to make more viruses, effectively turning our own cells against us?
Well, once integrated, the proviral DNA is essentially treated by our host cell as if it were one of our own genes. Our cell's own RNA polymerase then begins transcribing this proviral DNA to produce viral messenger RNA, or mRNA.
Using our own cell's equipment.
Exactly. This viral mRNA then serves as the complete blueprint for synthesizing various viral proteins, using the host cell's own ribosomes and protein-making machinery. In essence, the virus cunningly turns our healthy cell into a dedicated viral factory, just churning out viral components.
And after these viral proteins are made, how do they become new infectious viral particles ready to go out and infect more cells? It sounds like a highly organized assembly line.
It is a remarkably efficient, if insidious, assembly line. Those newly synthesized viral proteins, as we mentioned, are initially produced as long, inactive chains or precursor polyproteins. This is where the viral proteases, those molecular scissors, come back into play.
Cutting them up.
Precisely. They act with precision, cleaving these large polyproteins into their individual functional components. Once cleaved and properly folded, these functional proteins, along with new copies of the viral RNA genome, begin to self-assemble in the cytoplasm of the host cell, forming immature virions.
And then they get out.
They bud from the cell membrane, acquiring their distinctive outer lipoprotein envelope, in the process stealing that bit of membrane again, and finally mature into fully infectious viral particles, ready to spread the infection to new cells.
It truly sounds like a continuous, relentless viral factory, churning out vast numbers of new copies. And our sources mention that HIV replicates continuously, especially in the lymph nodes, releasing enormous numbers of new virions and infected T cells into the bloodstream. This constant production, even during the silent phase, must be one of its most devastating tactics.
It absolutely is. This continuous high-volume replication is the fundamental driver of the progressive damage to the immune system, even during that years-long asymptomatic phase. The sheer number of new virions constantly being produced and released into the bloodstream is just immense, relentlessly chipping away at the body's defenses.
And this leads us directly to its incredibly clever stealth strategy: evasion and the eventual devastating destruction of our immune system. How does HIV manage to initially avoid detection by our body's otherwise formidable defenses?
Well, one of HIV's most clever tricks for evading the immune system is its ability to pass directly from cell to cell through giant cell formation, a process called syncytia.
Syncytia, like merging cells.
Exactly. Instead of budding off and floating freely in the bloodstream, where it might be exposed to circulating antibodies or immune cells, an infected cell can directly fuse with an uninfected neighboring cell. This allows the virus to travel intercellularly, essentially moving from cell to cell without ever fully leaving the protective intracellular environment.
It's like an underground tunnel system for the virus.
That's a great way to put it. It allows it to bypass much of the host's immune surveillance for a significant period.
So it's essentially traveling underground, unnoticed by the immune patrol. But it also seems to have a way of actively blinding parts of our immune system to its presence. What's happening there with MHC class I proteins?
That's another sophisticated evasion tactic, yeah. A kind of molecular sabotage. HIV produces specific proteins, most notably TAT and NEF proteins, that actively downregulate or reduce the expression of MHC class I proteins on the surface of infected cells.
And MHC class I proteins are like flags.
Think of them as little flags, exactly, that infected cells wave to signal to cytotoxic T cells, our body's own killer cells. Hey, I'm infected, come and get me. By reducing the number of these flags, HIV effectively makes the infected cell less visible, less recognizable to those cytotoxic T cells, helping it evade detection and destruction. It's like dimming the lights on its own wanted poster.
And the cumulative effect of all these strategies, the continuous replication, the direct cellular destruction, these clever evasion tactics combined with the natural turnover of cells is a truly devastating impact on the immune system, particularly those CD4 T cells. Can you walk us through that relentless collapse of immunity?
Right. So the continuous replication of HIV, as we discussed, directly destroys cells that cytolysis, literally cell bursting. Adding to this, our own cytotoxic T cells, in their attempt to clear the infection, inadvertently contribute to the damage by destroying infected cells.
Friendly fire, almost.
In a way, yes. And naturally, T cells undergo terminal differentiation, meaning they just naturally wear out and die off over time. All of these factors combined lead to a drastic, progressive, and eventually profound reduction in the number of crucial CD4 T cells.
And why is that depletion of CD4 plus T cells so absolutely critical for our overall immunity? What's the real consequence of losing these particular cells?
Because CD4 plus T cells are the master regulators, the strategic command center of our adaptive immune response. They're indispensable for activating almost every other component of our immune system. Macrophages, cytotoxic T cells themselves, natural killer cells, even B cells which produce antibodies.
So they coordinate everything.
They coordinate pretty much everything. When these CD4 plus T cells are depleted, it's like cutting the main communication lines and disabling the generals of the immune system. This results in profound cell-mediated immunodeficiency, leaving the body terribly vulnerable to a whole host of pathogens it could normally easily fight off. It's the collapse of this central command system that tragically defines the later, most severe stages of the disease, leaving the body just wide open to attack.
That brings us to the progression from HIV infection to AIDS. It's crucial to understand that it's not a sudden event, but a journey, often with a silent battle occurring for many years before outward symptoms appear. Tell us about this crucial asymptomatic phase.
Yeah, the typical progression of HIV infection involves a significant asymptomatic period. This can last for a remarkably long time, often up to 10 years, according to our sources.
A decade, wow.
Yeah, a decade or even more sometimes. During this entire time, the virus is far from idle. It's actively replicating, silently but continuously, damaging the immune system. However, the individual might not show any overt outward symptoms, or perhaps only very mild, non-specific ones, like occasional fatigue or swollen glands, which makes early detection without testing incredibly challenging.
And the incubation period itself can vary quite a bit too.
It can. One of our sources notes it can range anywhere from 6 months up to 6 years, which highlights this variable but often very long silent battle happening inside.
So it's a quiet, unseen war waging inside the body, unnoticed by the host, until the immune system just can no longer compensate. And that brings us to the clinical onset of AIDS. It's important to remember, as you said, AIDS isn't the virus itself, but a collection of symptoms and illnesses that signal the catastrophic collapse of immunity. How is AIDS specifically defined in clinical terms?
Right. AIDS, acquired immune deficiency syndrome, is indeed the final stage of HIV infection if it's left untreated. It's a clinical diagnosis, meaning it's defined not just by the presence of the virus, but by the severity of the immune damage and the resulting characteristic illnesses. Crucially, AIDS is clinically defined when an individual's CD4 plus cell count drops below a critical threshold, 200 cells per cubic millimeter.
200. And what's normal again?
A normal, healthy CD4 plus count typically ranges somewhere between 500 and 1,500 cells per cubic millimeter. So once it drops below 200, the immune system is severely compromised. It's like a fortress with its walls crumbling.
And you mentioned HIV-1 and HIV-2 briefly before. Is there a difference in progression?
Generally, yes. HIV-1 is the most common type globally and tends to progress faster. HIV-2 is found predominantly in West Africa, tends to progress more slowly, is less easily transmitted, but can sometimes be more resistant to certain treatments. But the endpoint, AIDS, is defined the same way that sub-200 CD4 count.
Okay. And the really devastating part about AIDS is that people don't often die directly from the HIV virus itself, but from these opportunistic infections. What exactly are these, and why do they become so incredibly dangerous when the immune system collapses?
Opportunistic infections are precisely what their name implies. Infections that seize the opportunity presented by a severely weakened immune system. In a healthy individual, our immune system would easily fend off these pathogens, or maybe they'd cause only mild, transient illness.
Things we encounter all the time.
Exactly. Things that are often harmless residents in our environment or even living in our own bodies. But in someone with a compromised immune system due to AIDS, these common microbes suddenly become aggressive and cause severe, often life-threatening diseases. Our sources explicitly state that death in AIDS patients is often due to these opportunistic infections, which the body just can no longer cope with, rather than directly from the HIV virus itself. It's a tragic domino effect of immune failure.
Can you give us some specific examples of these opportunistic invaders that emerge when the immune system loses its defense? What kind of things are we talking about?
Certainly. We see a really wide spectrum of pathogens. For bacterial invaders, common examples include Mycobacterium avium complex, or MAC, and critically, Mycobacterium tuberculosis, the bacterium that causes TB.
Tuberculosis, right. That's a big one with HIV.
A huge one. Tuberculosis is a major co-infection and the leading cause of mortality in HIV/AIDS patients globally, especially in resource-limited settings. The weakened immune system just can't contain the TB bacteria.
And what about fungal infections? We'll touch on how these are often a telltale sign in the oral cavity later, but what are some key examples systemically?
Fungal foes are indeed very common. Candida species can cause candidiasis, often called thrush, which is particularly prevalent in the mouth and esophagus, causing those painful white patches. Another significant one is Cryptococcus neoformans.
Cryptococcus?
Yeah, that can lead to cryptococcosis, a very serious infection that frequently affects the brain, causing meningitis. Very dangerous.
And remarkably, viruses that our body normally keeps completely in check can reemerge with a vengeance. It's like our internal police force suddenly disappears.
That's exactly what happens. We frequently see conditions like Kaposi sarcoma, which is actually a type of cancer caused by the Kaposi sarcoma-associated herpes virus, also known as HHV8. It often appears as purplish lesions on the skin or mucous membranes.
Okay.
Then herpes simplex virus can cause extensive, persistent, and very painful lesions that are incredibly difficult to heal. Cytomegalovirus, or CMV, can cause severe disease in various organs. The eyes, leading to blindness, the lungs, the gastrointestinal tract.
And there are others too, right? Like PCP.
Yes. Pneumocystis jirovecii pneumonia, often abbreviated as PCP. You might also see it called Pneumocystis carinii pneumonia, or PJP. Same thing, just name changes. That's a severe lung infection. That was one of the defining illnesses early in the AIDS epidemic. And toxoplasmosis, which is caused by a parasite, can affect the brain, causing seizures and neurological problems. These are just some examples of the many infections that become deadly threats when the immune system has been utterly disarmed.
Beyond just infections, HIV and AIDS can manifest in various ways across different organ systems. It's not just about the immune system, is it? It's truly a whole-body assault. What are some of these systemic manifestations that can arise?
That's a crucial point to understand. The disease isn't confined to damaging just the immune system itself. In the pulmonary system, for instance, patients might experience symptoms like a persistent cough, sometimes with sputum, chest pain, and fever. Specific conditions include PCP, which we just mentioned, as well as TB and various severe bacterial pneumonias.
And the gastrointestinal tract seems to be heavily affected as well, leading to significant challenges for patients.
Indeed. Gastrointestinal issues are incredibly common and often debilitating. Chronic severe diarrhea is a major problem, along with significant weight loss and anorexia, loss of appetite.
What causes the diarrhea?
It can be caused by various pathogens like Salmonella, Shigella, Entamoeba histolytica, Clostridium difficile, Isospora, a whole range of bugs that wouldn't normally cause such severe problems. This persistent diarrhea and malabsorption contributes significantly to what's known as wasting syndrome, where the body literally wastes away.
It can also impact the brain directly, leading to quite profound neurological issues, which is a terrifying prospect.
Absolutely. HIV has the insidious ability to infect brain monocytes and microglial cells, leading to a range of neurological manifestations. Most well-known and devastating is HIV-associated dementia, sometimes called HAD, which can cause severe cognitive decline, memory loss, motor dysfunction, and significant behavioral changes. It profoundly impacts a person's life and autonomy.
And are there any other systemic issues that can arise in other parts of the body?
Yes, the ripple effect is wide-ranging. Patients can develop persistent generalized lymphadenopathy, which is chronic swelling of the lymph nodes throughout the body, especially noticeable in the neck. There's also a significantly increased risk of developing certain cancers, particularly lymphomas like non-Hodgkin's lymphoma. Largely due to the compromised immune surveillance, the immune system normally helps keep cancer cells in check.
And even salivary glands.
Yes, even the salivary glands can be affected, leading to xerostomia, which is chronic dry mouth, or sometimes even enlargement of the glands themselves, causing facial swelling. It truly underscores how pervasive and devastating the virus's impact can be throughout the entire body.
This sounds like an incredibly formidable foe, dismantling the body's defenses piece by piece. But humanity has rallied in an extraordinary way, leading to significant advancements in battling this virus. Let's delve into the three pillars of that fight: diagnosis, treatment, and prevention. First, how do we unmask the virus? How do we detect its presence as early and accurately as possible?
Early and accurate diagnosis is absolutely paramount, both for individual health and for preventing further transmission. There are several key methods for unmasking the virus, starting with sophisticated antigen and antibody detection tests.
So antigen detection, like the P24 antigen you mentioned earlier, is a way to catch it incredibly early, even before the body has had time to mount its full immune response. This sounds like a crucial early warning signal.
Exactly. The P24 antigen, that major core protein of the virus, serves as a vital early marker of infection. It can appear in the blood as early as 16 days after initial infection. This is particularly useful during what's known as the window period, that crucial time frame after initial infection, but before the body has produced detectable levels of antibodies.
How is it detected?
Usually with an ELISA or enzyme-linked immunosorbent assay using specific monoclonal antibodies designed to grab onto that P24 antigen. It gives us that critical early heads up.
And then the most common method of diagnosis involves detecting antibodies. How do these antibody tests work, and what's the typical timeline before they can reliably detect an infection?
Antibody detection, or serodiagnosis, is indeed the most common and widely used approach. We typically use screening tests first, which are designed to be highly sensitive, meaning they're very good at picking up the infection if it's there, minimizing false negatives.
Like ELISA tests?
Yes, various forms of ELISA are common screening tests, along with rapid tests like dot blot assays, latex agglutination, and comb tests. These are widely used for initial screening of blood serum or plasma samples. What's particularly useful for accessibility is that saliva can also be used for antibody testing in certain rapid test formats.
And how long does it take for antibodies to show up?
Typically, detectable antibodies begin to appear within 6 to 12 weeks after infection. By 6 months, almost all infected individuals will test positive. It's important to understand that the initial window period, where an infected person might test negative on an antibody test despite having the virus, can last around 3 to 4 weeks, sometimes a bit longer.
And if a screening test comes back positive, it always needs to be confirmed, right? Why is that crucial step necessary, and what are the gold standard tests used for confirmation?
Yes, confirmation is absolutely necessary. Because screening tests are designed for high sensitivity, they can occasionally produce a false positive result. So any positive screening test must be confirmed with a more specific test.
And the gold standard is?
The most widely used confirmatory assay, considered the gold standard, is the Western blot. This test is much more specific. It separates the viral proteins by size and detects antibodies against specific, distinct viral proteins like P24, GP41, and GP1 200160. If antibodies to a certain combination of these proteins are detected, it unequivocally confirms the presence of HIV infection. The indirect fluorescent antibody, or IFA test, is another reliable confirmatory option sometimes used. This two-step process screen, then confirm, ensures maximum accuracy.
Beyond antigens and antibodies, there's the incredible power of molecular tests, which can be unbelievably rapid and sensitive, even telling us about the activity of the virus. What role do PCR and viral load tests play in both early diagnosis and ongoing management?
Molecular methods have truly revolutionized HIV diagnosis and monitoring. They offer unparalleled speed, sensitivity, and specificity. They are particularly useful for very early diagnoses, sometimes detecting the virus within just 24 hours of infection, well within the window period for antibodies, and critically, for monitoring the course of the disease and the effectiveness of treatment. Polymerase chain reaction, or PCR assays, are the cornerstone here. They detect viral nucleic acids, either HIV DNA or RNA, directly.
And there's a distinction between DNA PCR and RNA PCR in what they tell us, correct? That seems important.
Yes, that's a very important distinction. DNA PCR primarily detects proviral DNA. That's the viral DNA integrated into our host cells, specifically in peripheral lymphocytes. This test is useful for confirming the presence of the integrated virus, particularly in tricky situations like diagnosing HIV in infants born to HIV-positive mothers, where maternal antibodies can interfere with standard antibody tests.
Okay, so DNA PCR confirms presence. What about RNA PCR?
RNA PCR measures the viral load in the plasma, the amount of free virus circulating in the blood. This includes various techniques like RT-PCR, reverse transcriptase PCR, NASBIA, TMA, and bDNA. Measuring viral load tells us the extent of active virus replication in the body. It's a crucial predictor of disease progression. Higher load usually means faster progression, and it's also the key indicator of how well treatment is working. The goal of treatment is to get the viral load down to undetectable levels.
Undetectable, that's the aim. And finally, beyond detecting the virus itself, we need to monitor the ongoing battle happening inside the patient's body. What are the key indicators clinicians rely on for that?
The most critical indicator for monitoring HIV infection and assessing immunological competence is, without doubt, the CD4 plus T cell count. We've already discussed how these cells are the indispensable conductors of the immune system.
Right, the sub-200 count for AIDS.
Exactly. So, tracking that count over time is crucial. A count below 500 cells per microliter suggests that the disease is progressing and the immune system is significantly weakening. And as we said, a count below 200 cells per microliter signals a high risk of serious opportunistic infections and definitively marks the transition to AIDS.
Are there other indicators besides CD4 count?
Yes, other indicators can be monitored too. Things like elevated levels of B2 microglobulin and neopterin in the blood can indicate immune activation and inflammation. General immunological abnormalities like lymphopenia and overall low lymphocyte count, and hypergammaglobulinemia, abnormally high levels of antibodies reflecting immune dysregulation, can also paint a picture of the ongoing immune system distress. But the CD4 count remains the primary benchmark.
So diagnosis has evolved tremendously, allowing for earlier detection and much more precise monitoring, which is critical. Now let's turn to treatment. The approach to HIV has been nothing short of revolutionary. What is the cornerstone of modern HIV treatment, and what are its ambitious goals?
The cornerstone of modern HIV treatment is antiretroviral treatment, or ART. Specifically, what's known as highly active antiretroviral therapy, or HART. The goals of ART are truly ambitious, but remarkably have largely been achieved for those with access. The aims are to inhibit viral replication to extremely low, often undetectable levels.
That undetectable viral load we mentioned.
Exactly, thereby significantly reducing morbidity, illness, and mortality associated with HIV, and dramatically improving both the life expectancy and the overall quality of life for individuals living with HIV. It really has transformed what was almost uniformly a fatal diagnosis into a manageable chronic condition for millions.
And why is it called highly active antiretroviral therapy? What does that highly active part imply about the treatment approach that makes it so effective?
The highly active part is key because HART typically involves a strategic combination of at least 2 and usually 3 or more different antiretroviral drugs. The critical aspect is that these drugs have diverse mechanisms of action. They attack the virus at different points in its intricate life cycle.
Hitting it from multiple angles.
Precisely. The idea behind this multi-pronged combination therapy is twofold. First, to suppress viral replication as completely as possible, and second, crucially, to minimize the development of drug resistance. By hitting the virus from multiple angles simultaneously, it's far more challenging for it to evolve resistance to all the drugs at once. This makes the treatment much more durable and effective in the long run.
Well, let's go through some of the main classes of anti-HIV drugs and quickly explain how they work. Starting with the early ones, nucleoside analog reverse transcriptase inhibitors, or NRTIs. How do they put a stop to the virus's replication?
NRTIs, which include drugs like zidovudine, famously known as AZT dadanacine lamivudine, these were among the earliest developed antiretrovirals. Their mechanism is quite clever. They mimic the natural building blocks, nucleosides, that the virus needs to make its DNA copy from RNA using reverse transcriptase.
So they're like decoys.
Exactly, they're faulty decoys. When the virus tries to incorporate these fake building blocks into the growing DNA chain, they immediately stop the reverse transcription process dead in its tracks. They act as chain terminators, preventing the viral RNA from being fully converted into DNA.
And then there are non-nucleoside reverse transcriptase inhibitors, or NNRTIs. How do they differ in their approach to the same enzyme, reverse transcriptase?
NNRTIs, which include drugs like nevirapine and efavirenz, also target the reverse transcriptase enzyme, but they do so in a completely different way than NRTIs. Instead of mimicking building blocks, they bind directly to a specific site on the enzyme itself, but not the active site where the building blocks bind.
So they stick somewhere else on the enzyme.
Yeah, they bind to a different pocket on the enzyme, and this binding essentially gums it up, altering its shape so it can no longer function properly. They're more like a wrench thrown into the gears of the reverse transcriptase machinery, rather than a faulty part.
Next up, protease inhibitors, or PIs. This sounds like they're directly targeting that molecular scissors protease we discussed earlier, preventing the virus from assembling itself correctly.
Precisely. Protease inhibitors, a class that includes drugs like saquinavir, ritonavir, indinavir, nelfinavir. They specifically inhibit the viral proteases. As we discussed, these proteases are essential for cleaving those large precursor polyproteins into their individual functional vital components needed to build new infectious viruses.
So they stop the final assembly step?
Essentially, yes. Without this crucial cleavage step, the new viral particles cannot mature properly and are not infectious. PIs effectively shut down the virus's assembly line and prevent it from producing viable new threats.
And the relentless research into HIV has led to even newer drug classes that target other parts of the viral life cycle, providing even more powerful tools. Can you tell us about those?
Yes, as our understanding of HIV's intricate life cycle deepened, new vulnerable points emerged, leading to even more innovative treatments. For instance, we now have fusion inhibitors, like enfuvirtide. These work by blocking the HIV envelope, specifically that GP41 protein, from physically merging with the host cell membrane.
So they stop it getting in.
Exactly. They prevent the virus from even entering the cell in the first place. Then there are integrase inhibitors, such as raltegravir. These interfere with that absolutely crucial step of viral DNA integration into the host genome, blocking the integrase enzyme.
Stopping it from becoming permanent.
Right. These newer classes have provided even more powerful options for combination therapy, particularly for patients who might develop resistance to older drugs, and they further improve patient outcomes and tolerability.
It's truly remarkable how far treatment has come, transforming the landscape for millions. But despite the dramatic clinical improvement with HEART, it's essential to emphasize, as you said before, that it's not a cure. Why is that crucial distinction so important for people to understand?
This is a critical point that cannot be overstated. While HEART has indeed transformed HIV from effectively a rapid death sentence into a manageable chronic condition for many, it is not a cure. This is fundamental because the virus can persist intracellularly as a provirus, that integrated viral DNA we discussed permanently embedded within the host cell's genome in long-lived cells, forming latent reservoirs.
Hidden reservoirs.
Exactly. These reservoirs are largely invisible to the immune system and unaffected by current ART drugs, which only target actively replicating virus. This means that therapy must be continuous and lifelong. If treatment is stopped, even for a short period, the provirus in these reservoirs can reactivate, and the virus will inevitably begin replicating again, leading to a rebound in viral load and disease progression. It's a permanent guest that needs constant management.
And what are some of the ongoing challenges? Despite these incredible breakthroughs in treatment, it's clearly not a simple fix, even with the drugs.
Challenges certainly remain. While greatly improved over the years, side effects of the medications can still impact a patient's quality of life, sometimes requiring switches in regimens or complex management. Furthermore, maintaining strict, lifelong adherence to a daily medication regimen can be incredibly difficult for some individuals, and lapses in adherence can lead to treatment failure and drug resistance.
And access is still an issue.
Access remains a huge issue. Critically, the cost of treatment, while reduced, especially in low- and middle-income countries, continues to be a significant barrier to universal access. Ensuring everyone who needs treatment can get it and stay on it is a complex global health equity issue that requires ongoing effort and resources.
Beyond treatment, prevention is always key in battling any infectious disease. What are the primary strategies for preventing HIV transmission on a global scale?
Prevention strategies broadly focus on raising awareness and promoting safe practices to interrupt the known modes of transmission. This includes comprehensive health education campaigns, promoting safe sexual practices through consistent and correct condom use, and crucially, harm reduction strategies like providing clean needles and syringes for people who inject drugs to avoid needle sharing.
And blood safety.
Absolutely essential. Screening of all blood donors and blood products is a cornerstone of prevention, ensuring the safety and integrity of the blood supply for transfusions. These basic public health measures have had a massive impact.
And there's a specific emergency treatment available after potential exposure called post-exposure prophylaxis, or PP. How does that work, and for whom is it primarily intended?
PPP is a vital intervention, essentially an emergency medical response available after a potential exposure to HIV. This could be in cases of accidental needle sticks or sharps injuries in healthcare settings, or certain non-occupational exposures like sexual assault or condom failure with a known HIV-positive partner.
How quickly does it need to start?
For PEEP to be effective, it must begin within 72 hours, 3 days after the exposure, and ideally as soon as humanly possible. The sooner it started, the better the chance it has of working. It works by trying to prevent the virus from establishing a permanent infection after it's entered the body.
What does the regimen involve?
The regimen typically consists of taking 2 or 3 anti-HIV medications every day for 28 days. It's essentially a short, intensive course of Artine to try and hit the virus hard before it can fully establish those latent reservoirs.
So it's a short, intensive course of medication to try and prevent the virus from taking hold after a specific incident. Our sources specifically mention healthcare workers having a risk. What's that risk like for them through, say, a needle stick?
Healthcare workers do face occupational exposure risks, primarily through percutaneous injuries like needle sticks or cuts with sharp instruments contaminated with blood, or sometimes through splashes of blood or other potentially infectious body fluids onto mucous membranes like the eyes or mouth. However, it's crucial to highlight that the actual risk of HIV transmission through these specific routes is very low.
How low?
The average risk after percutaneous exposure, like a needle stick with HIV-infected blood, is estimated to be around 0.3%, or about 1 in 300. The risk from a mucous membrane exposure is even lower, about 0.09%. It's significantly lower, for instance, than the risk of acquiring hepatitis B virus from a similar needle stick injury, which can be as high as 30% if the source patient is highly infectious and the worker isn't vaccinated.
So low, but not zero.
Exactly. It doesn't mean complacency is acceptable, which is why PK is available and universal precautions are so vital. But it does put the professional risk in a clearer, more informed perspective.
And finally, the holy grail in infectious disease control, something we chase for every major pathogen, a vaccine. What's the current status of an HIV vaccine, and why has it remained so incredibly elusive despite decades of intensive research? It seems like we should have one by now.
The development of an HIV vaccine is an ongoing, incredibly challenging scientific endeavor. It's truly one of the toughest puzzles in vaccinology. Despite decades of dedicated research, numerous clinical trials, and billions of dollars invested, a safe and broadly effective preventive vaccine remains elusive.
Why is it so hard?
The major challenges lie deep within the virus's inherent characteristics. Firstly, its immense antigenic diversity. HIV exists as numerous different subtypes and strains around the world, and even within a single infected person, it constantly mutates. This means a vaccine developed against one strain might not protect against others. It's like trying to hit a constantly changing target.
The mutation rate is high.
Extremely high. Its reverse transcriptase enzyme is very error-prone, leading to rapid mutations. This allows it to quickly adapt and escape any immune responses that are generated, whether by natural infection or potentially by a vaccine. And then there's its insidious ability to establish latency by integrating into the host genome, essentially hiding from the immune system in those dormant reservoirs we talked about.
So it hides from the vaccine's effects, too.
Potentially, yes. It's very difficult for a vaccine to target or clear out these latent cells. These factors, the diversity, the high mutation rate, the latency, make it incredibly difficult to develop a vaccine that can elicit broad, protective, and durable immunity against the many circulating strains of HIV. It's a frustratingly complex dance with a constantly shape-shifting foe.
This brings us to a unique and critical area that might surprise some of you. The profound insights gained from dentistry regarding HIV. It might seem unexpected, but the oral cavity actually offers some of the earliest and most telling indicators of HIV infection. It makes dentists frontline detectives in a way.
That's absolutely right. The oral cavity is often a remarkably sensitive window into the systemic health of an individual. And for HIV, it can provide crucial early warning signs of immune compromise, sometimes even before the person knows they're infected.
Really? How many signs are we talking about?
Our sources indicate that some 50 distinct disease entities can potentially affect the orofacial region, the mouth and face in HIV-infected individuals. Many of these are quite characteristic and can appear even before other systemic symptoms become obvious. The mouth isn't just for eating and talking, it's a critical early warning system for HIV, revealing that silent battle waging inside the body.
So what kinds of specific clues are dental professionals looking for in the mouth? Let's start with fungal, viral, and bacterial infections that can manifest orally. Fungal first.
Oral candidiasis, or thrush, is highly common, especially in the early stages of HIV infection, making it a powerful early indicator. This fungal infection typically presents as erythematous, which means red, inflamed patches, or as pseudomembranous white plaques that look like cottage cheese and can often be wiped off, leaving a red surface underneath.
And that's a bad sign.
Its presence, especially if it's severe or recurrent, is considered a very reliable and often ominous prognostic indicator. It signals a significant decline in immune function and often precedes the progression to full-blown AIDS. Other fungal manifestations can include linear gingival erythema, a distinct fiery red band along the gum line, and angular cheilitis, which causes painful cracks and inflammation at the corners of the mouth, possibly due to mixed fungal and bacterial infections.
And what about viral infections showing up in the mouth? It sounds like the mouth can be a veritable viral roadmap.
It really can. For viral infections, we frequently see extensive and persistent herpetic stomatitis caused by the herpes simplex virus. In people with HIV, these cold, sore-like lesions can be much larger, last much longer, and be much more painful than usual.
Okay, what else?
Herpes zoster, or shingles, can also manifest orally along nerve pathways. Papillomas, which are wart-like growths caused by human papillomavirus, HPV, can appear. Kaposi sarcoma, that HHV-8-associated cancer, frequently appears in the mouth, often starting as flat or raised purplish or reddish lesions, typically on the palate or gums.
And there was one specific white lesion you mentioned.
Yes, hairy leukoplakia. This is a very specific and highly significant viral lesion. It's typically an asymptomatic, corrugated, or hairy-looking white patch found on the lateral borders, the sides of the tongue. It's caused by the Epstein-Barr virus replicating in the epithelial cells. Its presence is a strong indicator of a poor prognosis, as most affected patients historically developed AIDS within about 3 years if untreated. It's a critical red flag for clinicians.
And bacterial clues. Beyond the usual suspects like cavities or standard gum disease, are there specific bacterial infections that stand out in HIV-positive individuals?
Yes. In terms of bacterial infections, HIV-infected individuals can develop unusual and particularly aggressive types of periodontal diseases. These include necrotizing ulcerative gingivitis, or NUG, and necrotizing ulcerative periodontitis, NUP.
How are they different?
They are distinct from the typical forms of gum disease, and even from what used to be called ANU in otherwise healthy people. In HIV, these necrotizing conditions have an unceasing, relentless progression, often causing rapid destruction of gum tissue and even underlying bone, sometimes despite standard dental treatment. They really highlight the profoundly compromised immune response. Atypical mycobacterial infections related to TB, but caused by different mycobacteria, can also occasionally be found in the oral cavity, often presenting as non-healing ulcers or swellings.
You also mentioned some specific oral diseases like vesicles with ulcerations from HSV and periodontitis progressing to gingival necrosis. These sound particularly severe and indicative of profound immune damage.
They absolutely are. The vesicles and ulcerations from herpes simplex virus can be much more extensive, persistent, and agonizingly slow to heal in HIV-positive individuals due to their severely weakened immune systems. And periodontitis progressing to actual gingival necrosis means the gum tissue is dying off, potentially exposing the underlying bone. This is a stark and deeply concerning manifestation of how aggressive these normally manageable infections can become when the body's primary defenses are disarmed by HIV.
This leads perfectly into the crucial discussion of infection control in healthcare settings. It's fair to say that the advent of HIV fundamentally reshaped how dental and other healthcare practices operate globally, right? It forced a massive paradigm shift.
It truly did. The appearance of HIV in the early 1980s and the fear and uncertainty surrounding it led to an unprecedented increase in the regimentation and stringency of infection control practices, not just in dentistry, but across all healthcare disciplines. It compelled a radical change in how we approach potential contagions in healthcare.
How are things done before?
Before HIV, precautions were often based on a patient's known diagnosis or perceived risk. HIV forced the realization that you couldn't always know who was infectious, especially given the long asymptomatic period. This led directly to the development and adoption of what were first called universal precautions, and now more broadly termed standard infection control precautions, or SICPs.
Let's clarify the transmission risks in a clinical setting again. While HIV is primarily transmitted sexually by blood-to-blood contact or perinatally, what's the actual risk in, say, a dental office for healthcare workers? We touched on needle sticks, but saliva.
Right. In a healthcare setting, the primary concern for occupational transmission remains accidental injuries via contaminated sharps. As we said, the risk from a needle stick is low, around 0.3%. As for saliva, transmission by saliva is considered very unlikely in the absence of visible blood.
Why is that?
It's due to a combination of factors. The viral titer, meaning the concentration of virus, is generally extremely low in saliva compared to blood. Plus, saliva contains inhibitory factors like certain enzymes and antibodies such as IgA and salivary leukocyte protease inhibitor, SLPI, which can actually neutralize or inhibit the virus. So routine dental procedures themselves are not considered a significant risk for salivary transmission.
This low risk is important context, but it absolutely doesn't mean we can be complacent. This is where standard infection control precautions come in. What's the core underlying concept here that transformed healthcare safety?
The core concept of standard infection control precautions, or SICPs, is absolutely paramount and represents that fundamental paradigm shift. All patients are to be treated as if they're potentially carriers of infectious diseases, regardless of their known infection status or medical history.
Treat everyone the same.
Exactly. This means strict, unwavering adherence to these precautions is non-negotiable for every single patient, every single time. You cannot categorize patients as high or low risk based on their history or appearance. The precautions apply universally. This protects both the patient from cross-infection and the healthcare provider. It's a fundamental principle of modern healthcare safety.
So it's about having a standard operating procedure for every patient interaction. What are the key components of these SICPs that are now standard practice in virtually every healthcare setting, especially dentistry?
Okay, key components include, first and foremost, personal protection equipment, or PPE. This means the routine wearing of disposable gloves, typically nitrile, latex, or vinyl for exams, and sterile gloves for surgical procedures. It also includes wearing face masks and protective eyewear or face shields to protect the mucous membranes of the eyes, nose, and mouth from splashes or sprays of potentially infectious material. These create a physical barrier.
And meticulous hygiene, of course, must be fundamental.
Absolutely critical. Meticulous hand hygiene is arguably the single most important measure for preventing the spread of infections. This involves thorough hand washing with soap and water, or using alcohol-based hand rubs before and after patient contact, after touching potentially contaminated surfaces, and after removing gloves. Dedicated hand-washing facilities, ideally with no-touch controls, are essential.
Sharp safety is another huge one, given the risk of needle sticks and cuts we discussed. What are the protocols there?
Yes, sharp safety is vital. This involves careful handling of all sharp objects like needles, scalpel blades, and dental instruments. Used sharps must be immediately disposed of in approved puncture-resistant containers located close to the point of use. And a crucial rule, now standard practice worldwide, is that needles should not be recapped using a two-handed technique. Safe techniques like the one-handed scoop method or safely engineered devices must be used if recapping is unavoidable, but direct disposal is preferred. It's all about minimizing the chance of accidental injury.
And then there's instrument sterilization and disinfection. How does that protect patients and staff? And what do those terms specifically mean in this context? How effective is it against HIV?
Instrument processing is crucial for preventing patient-to-patient transmission. All reusable instruments that penetrate tissue or contact sterile areas, especially those used intraorally, like dental handpieces, burrs, and surgical tools, should ideally be sterilized. Sterilization kills all forms of microbial life, including bacterial spores, rendering the instrument completely safe.
And disinfection.
If an item cannot withstand sterilization due to its material, it should undergo high-level disinfection, which kills most pathogenic organisms, but not necessarily all bacterial spores. Fortunately, HIV is relatively fragile outside the body. It is readily inactivated by heat methods like autoclaving, steam under pressure, or dry heat ovens are highly effective, and also by common chemical disinfectants like 10% household bleach solution, sodium hypochlorite, 50-70% ethanol, or 2% glutaraldehyde. So standard sterilization and disinfection protocols are very effective at eliminating HIV from instruments and surfaces.
And finally, even with universal precautions applying to everyone, a thorough patient evaluation and medical history is still a crucial part of the process. What's its purpose now? if not for risk stratification.
Correct. A thorough and confidential medical history should always be taken and updated regularly for every patient. However, the purpose of this history, in the era of SICPs, is not to categorize patients as high or low risk in order to decide whether to use precautions, because, again, SICPs apply universally. Instead, the medical history is vital for understanding the patient's overall health picture, identifying any specific medical conditions like bleeding disorders, allergies, or conditions that might affect healing, knowing what medications they're taking, and understanding any particular needs or sensitivities they might have that could impact their dental care planning and treatment. It's about providing safe, effective, and individualized care, not about deciding who gets basic infection control.
Lastly, what about the occupational responsibility and safety for dental personnel themselves, given their routine exposure to blood and saliva?
While the occupational risk of contracting HIV infection specifically is very low, as we've noted, dental personnel are routinely exposed to numerous infectious diseases through their work. Therefore, they have a profound ethical and moral responsibility to maintain their own health and to seek appropriate medical evaluation and advice if they believe they might be infected with HIV or any other significant bloodborne pathogen, like hepatitis B or C.
And if they are infected?
Critically, they must adhere to scientific and ethical guidelines, which may involve modifying their practice or, in some situations, ceasing to perform certain exposure-prone procedures if there's a risk of transmission to patients, guided by expert medical and public health advice. Furthermore, immunization against common vaccine-preventable bloodborne pathogens, particularly hepatitis B, is strongly recommended, really essential, for all dental staff to proactively protect themselves. It's a fundamental commitment to both personal safety and the safety of the patients they serve.
So, that concludes our deep dive into HIV and AIDS. We've unpacked its unique retroviral nature, its incredibly complex and, frankly, insidious life cycle within the human body. From that ingenious infiltration using CD4 receptors and co-receptors, right through to the devastating progression to AIDS defined by immune collapse. It's certainly a story of a tiny foe with immense biological cunning.
We also thoroughly explored the truly revolutionary impact of antiviral treatment, ART, in managing this infection, how combination therapy, HART, transformed what was once an almost inevitable death sentence into a manageable chronic condition for many, offering profound hope and longer lives. And importantly, we saw the critical role of standard infection control precautions in healthcare, fundamentally changing practices like those in dentistry to ensure safety and dignity for everyone involved.
It's truly a story of scientific ingenuity, massive global collaboration, and incredible human resilience in the face of a microscopic threat that has forever altered our understanding of public health, hasn't it?
It really has. The scale of the response, scientifically and socially, was unprecedented.
So, given what we've unpacked about HIV's incredible adaptability, its stealthy mechanisms like latency, and our persistent struggle to develop a truly effective universal vaccine, what does this ongoing dance between human biology and microscopic life forms tell us about the future? And how might these profound lessons from battling HIV lessons about rapid scientific discovery, the need for robust global health infrastructure, the absolute necessity of universal precautions, how might those inform our approach to future global health challenges, perhaps even those we haven't yet encountered?
That's the big question, isn't it? I think the ability of a virus like HIV to evolve so rapidly, to hide so effectively, and to systematically dismantle the most sophisticated defense system known to the human immune system, it highlights the constant evolutionary pressure exerted by pathogens. But the success we have had in managing HIV isn't just about the brilliance of the drugs. It's about that global, multifaceted approach. It involved relentless science, yes, but also robust public health initiatives, activism, political will, and a collective sense of social responsibility to reduce stigma and ensure access.
A whole system response.
Exactly. This holistic adaptive response to HIV isn't just a historical achievement. I think it's a living blueprint. It shows how humanity must confront future pandemics and the ever-present, ever-evolving microscopic threats that share our world. It requires science, yes, but also equity, collaboration, and vigilance.
Absolutely. Well, we encourage you, our listeners, to continue your own deep dive, reflecting on the surprising facts and profound insights gained today about this remarkable virus and our ongoing battle with it. Thanks for joining us on the deep dive.